We have with us Professor Dr. Vivek Gupta, Senior Consultant Interventional Cardiologist from Apollo Cardiac Care, New Delhi. Sir, welcome to the show. Sir, we would like to know what is the incidence of aortic valve stenosis and how TAVI is useful in these conditions?
You see, aortic valve stenosis we are talking today is a degenerative aortic valve stenosis. We are not talking about the rheumatic stenosis. So overall the incidence is getting high and high because this is a disease of the degeneration and degenerative, and this happens mostly after the age of 60-65. Of course, there are some predominant factors which can lead to this, but aortic valve stenosis in such generally 26% of the population, they suffer from mild, moderate to severe stenosis. Out of this, 2% are symptomatic. So it's a huge number, and the numbers are going to increase exponentially as the lifespan is increasing. As you know, that the people are, of course, are healthy and living till the age of 80, sometime 90. The average lifespan in France, for example, is 83 years for female. Similarly in India also, that we are expecting more and more lifespan with the more of medical treatment for the elderly population. So the transcatheter, what we are talking not about is transcatheter aortic valve implantation. A transcatheter aortic valve implantation is a non-surgical technique. It is a non-surgical technique for the treatment of degenerative severe aortic valve stenosis. Let me tell you that surgical aortic valve replacement has been the treatment for the care, and for decades together we have been treating all the patients of degenerative aortic valve stenosis with surgical aortic valve replacement, done by, of course, with the open chest and an open heart. Unfortunately, with the increasing age, these becomes very high risk patients, especially with there are comorbid factors like previous bypass surgery or associated lung disease or associated kidney diseases. And these patients are generally declined for surgery, and therefore they have to live either with the medical treatment, which is not enough, and therefore they are destined to die within few years of time. Overall lifespan, once the severe aortic valve stenosis is diagnosed, is not more than 6 months to 2 years, if not treated by surgically. And therefore, with Professor Alan Krieger working especially with a balloon aortic valvuloplasty done by him for the first time in 1985, which was published in New England Journal of Medicine, and then he was working on it to develop a technique where you can open, without opening the chest, if you can put a valve across the aortic valve, biprosthetic aortic valve. And the first case was performed by him only on April 16, 2002 in Hospital Charles Nicolle in France in Rouen. I was privileged to be part of this innovative technology during the animal experimentation in 1996, 97, 98, and since 2002, when the first case was performed in April in France, there were a lot of trials and registries further, and now at this point of time, this is currently established procedure, especially in high risk or intermediate risk patients. The procedure is performed through the groin. It is done through the femoral artery at the moment, which is known as antegrade approach, where the catheter takes the valve from the common iliac artery, from the descending aorta, all up to way to the transverse aorta, and then of course it reaches the aortic valve area with the help of course cine-guided one, just like any angioplasty or stent procedure for the coronary arteries. But this is of course the more bulky, and therefore you require at least 14 French sheath to insert this valve. And once it is done, the procedure is done in a conscious sedation patient. This does not require a general anesthesia as of now, and the procedure time is not more than 40 minutes to 1 hour in experienced hands. There are no major complications as such, except for the requirement of the pacemaker, which happens only 2 to 5% of patients. Of course, you have to be trained enough. It is a slightly more challenging to study and to learn, and currently this is being done in most of the centers in Europe and USA, especially FDA approved it in 2014 for the high risk and intermediate risk patients. And also the CE mark came, and CE mark is for the European centers where it is commercially available, came up in 2009. So as of now, many patients are being treated like this, and this is actually a lease of life, because these patients who are high risk especially, they cannot be operated. And if you do operate a high risk patient, the risk is more than 20% sometimes, and the mortality, and surgeons do not try to take up this case, and also the patient family do not actually agree for such a high risk procedure, and therefore they are destined to die.
So what are the different kinds of valves that are used in the procedure TAVI?
Yeah, as I have told you that the first case which was done by Professor Alan Krieger, this was a transseptal approach. I should tell you that when they were doing for the first time, it was a transfemoral approach, where they had gone from the femoral vein into the right atrium and then crossing to the left atrium and then going to left ventricle, and it was a retrograde approach. So this was the two types of currently valve are available. One is of course the balloon expandable. This is balloon expandable valve, which is available by the name of Edwards Sapien valve. It was earlier known as Krieger-Edwards valve, and this is the balloon expandable valve, which is at the moment the market share is about 70% overall. The second valve which came up was actually the core valve, which is a self-expanding valve, and which is now promoted by company Medtronic, and the market share is about 38%. The difference between these two techniques is that of course the self-expandable valve is core valve. It is the technique is same, both are being integrated approach, but of course the companies are promoting this, and one has to be actually skilled to do either of the two technique, and one has to choose between them. Personally, the pacemaker implantation is more required in core valve, while in Edward valve the pacemaker requirement is less, but overall the patient goes very well in both the patients.
So having looked into the definitive use of TAVI in aortic valve stenosis, what would you say are the clear-cut indications for use of this procedure in
very important, you see, whenever a new technology is introduced, it has to be actually certified and compared with the current available techniques. For example, surgical aortic valve replacement has been used for these patients for decades altogether. So when the first case was performed by Dr. Alan Crebier in 2002, several registries followed, and of course later on the trial comparison, direct comparison of the transcatheter valve implantation, which is a non-surgical technique, versus the surgical valve implantation, which is SAVR, was done by partner trials, which was a combined study from various centers, mostly both European and American, and partner A and partner B both confirmed. Initially they confirmed that in inoperable patients it is much better than surgical aortic valve replacement, and of course with the high risk patient also it is better than surgical aortic valve replacement. Though currently there is no doubt, FDA has also approved that inoperable as well as high risk surgical patient, that means high risk means those patients who have associated comorbidities, especially after the age of 80, 85 or 75, 80, if they have a previous bypass surgery, poor lung function, poor ejection fraction, associated nephropathy, or any other kind of disease which gives a contraindication to general anesthesia as such or lung procedure. Of course, this is clearly indicated. In intermediate risk patient, that means those patients who are otherwise can also be taken up for surgical aortic valve replacement. But those patients, of course, when you do non-surgically, it is much easier procedure. The recent trials have shown that even in intermediate risk patients, TAVI is already comparably, and also the few trials have shown that it's better than surgical aortic valve replacement in terms of stroke, in terms of other complications which can happen in either of the two procedures. In normal risk patient, that means the patient who can otherwise be taken up by surgeons by surgical aortic valve replacement, the trials are ongoing, especially those two trials which are there, SAPIEN 3 trial as well as TAVI trial for core valve. The results will be available very soon, within 1 or 2 years time. But of course, independent registries, depending upon the patient's availability and patients not willing for surgery, even the normalist patient can also be taken by this technique if the cost is affordable, and also if it is the patient family does not want it. So high risk, inoperable, intermediate risk, there is no doubt. But normalist patient, I think few years more we have to wait for comparing or applying for the superiority of TAVI, which is transcatheter aortic valve non-surgical treatment versus surgical aortic valve replacement.
Thank you very much, sir, for that descriptive talk on aortic valve stenosis and use of TAVI in such condition. Thank you so much, sir. It was a privilege having you on the show.